Okay, I think we can start now. Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. Good evening, good afternoon, good morning to all our colleagues that are participating with us. Hello, dear colleagues here in the panel, Dr. Hassan, Dr. Tariq, and Dr. Fahad. He will join us after a while. This is the last, well, let's say, the last session or the last webinar for MEOM. And MEOM is the Middle East Ophthalmology meeting that I think most of you, they join us during this year. And hope, inshallah, next year it will be more better and more, we are having a lot of preparation for the next year. And we are having courses and instructional courses, educations for that will be conducted in the next year. And also I would like to announce the seventh quick that will be held virtually in 10 to 12 of February 2022. I would like to welcome all of you, and today we'll have a very interesting topics that we'll discuss. And I will start with giving one presentation, a case presentation. The title of this session is Unusual Medical Retinal Presentation. Let's see what our colleagues they are going to present. My case is a direct, but we will highlight about certain points. So let's start on this case. This is a 50-year-old male patient. He is diabetic for 13 years, presented with history of blurred vision in both eyes. On examination, we found that his visual acuity 0.15 without correction, and it is the best corrected visual acuity. It is the best corrected visual acuity. No improvement beyond 0.15 in the right eye, and counting finger on 2 meter. On slit lamp examination, the anterior segment with a normal limit, the intraocular pressure in both eyes with a normal limit. Fundus examination, we found that patients have severe non-proliferative diabetic retinopathy with maculopathy and heart exudate with significant cystoid central serous macular edema. OCT in the right eye was 500, in the left eye was 640. This is the fundus of the right eye. You can see, I think, the diabetic changes and how the severe of the exudate present in the macula with also macular edema. This is also the left is more severe, I think, in comparison to left, or almost you can say similar, but I feel the left eye more severe than the right eye, and the edema is more on the left eye. This is the OCT. You can see this is the OCT, mainly diffuse macular edema involving the central also macular edema. Central it was 390, but around the or parafoveal it's reached to up 640 as we mentioned earlier. You can see, I want you to see this picture nicely and to see how is the elevation of the edema surrounding the macular region. Here I think is in the center 390, but here and all around it reached in the highest point to about 640. This is also the fundus and this is the left eye. You can see the video showing how the diffuse macular edema, and also we can play this again if you want to see. So you can find it reached to about 630, 640 in highest parafoveal. So what to do next? If I want to ask dear colleagues, what are you going to do here? Start treatment with anti-VEGF, focal laser, start treatment with steroid, laser, and anti-VEGF. Okay, Dr. Tariq, what is your plan after you see this patient? Just we want to select and tell why.
I mean, looking at this patient, I mean, his vision is quite low in both eyes, especially the left eye. And it does seem from the color photos that his diabetic macular edema is quite chronic. And I think his prognosis is not going to be good at all because of the oxidative plaques, as you can see, encroaching to the fovea, mainly in the left eye more than the right eye. I think fundus fluorescein angiography is advocated here to just to see if there's any macular ischemia, so you can really explain to the patient about his visual prognosis. But traditionally, I would go with the anti-VEGF medications, at least 3 to 5 injections, either Eylea or Lucentis. Then I'll decide from there, do I need to go for steroid or not? I mean, definitely focal laser is not going to work at all here. Diffuse edema is not going to help you at all.
Okay. Dr. Hassan, you have any other opinion different what Dr. Tariq mentioned?
As Dr. Tariq mentioned, is just see the treatment is the first line is the anti-VEGF, and mostly I will request some systemic profile to rule out any lipid dyslipidemia, because as the patient has excessive exudates, so just I will request some systemic, but the plan is the same. Just I will give 3 anti-VEGF and I will evaluate the patient after that.
Okay. So patient was given, as you or agreed on, was given an anti-VEGF Eylea in the left eye, and follow up after 1 month, the left eye visual acuity in the left eye improve, which was counting finger, I think 2 meter to 0.05, and the OCT decreased from 6 something to 430. I can show you now the OCT. This is the left eye, only you can see only from 1 month. And this is, I mean, that one, the fundus, and this is the OCT. You can see in the center also is decreasing from 391 or 51 up to 135 in the center. And I told you to remember how it was the edema surrounding the fovea in the first picture. And you can see now how it's decreasing, and you can see this in the map, macular map. And this is also a fundus camera with, and I want to show also the video here. I think you can, okay. I want also maybe, okay, repeat. This is the comparison, sorry. This is the comparison between the pre-injection. You can see the as a fundus now. And this one, it's you can see there is some decrease in also the exudate, which is, I don't know, we will discuss this one if that can happen after only 1 injection or not. This is the pre-injection OCT, and this is the post-injection. You can see this one also, pre-injection, post-injection, the map. You can see here fluorescein, 3 fluorescein angiogram, and you can see the difference. There is some decrease, especially in this area in comparison on that area. So, okay. Comparison also in the videos. You can see how it was a severe diffuse macular edema, and it wasn't. So after the third injection, now I take you immediately to the after the third injection in the left eye. I'm concentrating here on the left eye because I was treating the right eye in another way, actually. Maybe I will let you know after I finish this presentation. Here, the left eye, it is 0.15 from only counting finger to meter. And the left eye in the whole, it was left 500. As we mentioned, this parafoveal, but in the foveal, it was more or less than that. This is, you can see, I think, the fundus, and this is the here.
294.
Yes, you can feel, I don't know, you notice that the edema, it is little bit, also even after the third injection, it's little bit more than what it was after the first injection. You notice that?
Yes.
Okay, so here, I mean, the vision improve, but I mean, I can say the OCT, it's not improving as I was expecting. Maybe after the first injection, it was improving more better, but after the third one, it is starting increasing. So what to do next? To continue with anti-VEGF Eylea, change to another anti-VEGF, or change to steroid?
I would finish 5 injections of Eylea as per Eylea protocol in diabetic macular edema.
Okay, Hassan?
Yes, the same is because if you have there's respond in the first injection and second injection. What happened the third injection? So maybe I will do some for the patient, but I will continue for the 5 consecutive injection. Then I will see. I will evaluate the patient.
Why there is, okay, let us continue. Maybe I will ask the question after. So I continue actually, as you mentioned, all of you. So we agree on the plan of treatment. We continue with anti-VEGF Eylea. Patient was having another 4 injection, actually. He received, and this one, a follow-up after the 7th injection. The visual acuity improved to 0.3. The OCT now 300 in the left eye. In the periphery was 400, but centrally is reached to up 300. And this is the fundus, how you can see the fundus. You can see here also the reduction in the periphery or parafoveal less than what it was before, even after the 7 injection. And here also the fluorescein, fundus fluorescein. And here pre-injection, you can see here, this is the pre-injection. The first injection, it was this one, and this is the post-injection OCT. That's the last one. This is the last pre-injection, and this is the last one of 7th injection. We found this one. This is the map. And this is also the fundus fluorescein. And this is the videos. You can notice both of them working at the same time. So there is a huge changes in the response from the first time he present and after 7th injection of Eylea. That's what my case. So just I want to highlight a certain point that even not only here, you can see there is no, I didn't concentrate here only on the edema itself, but there was a response on the treatment for the exudate. There is, I don't know if you remember the photos, if I go to the photos, or you can see here, you can see here very less exudate in comparison to the first time he present. That means we are not only treating and the patient in regarding the diabetic macular edema, but also the diabetic retinopathy, which is here represented by exudate. Is there any comment or any question from Tariq or Dr. Hassan?
I think it's a brilliant response to the anti-VEGF, Dr. Muhammad, as his vision was counting finger has gone up to 0.3, you know, and his exudate has gone down dramatically, as you can see between these 2 pictures, left hand to the right hand, you know. So I'm sure if you do fluorescein angiography now, I'm sure you can find some element of ischemia in this gentleman. He might not really be able to improve his vision anymore. Plus, he has arrived late to you, later presentation. Chronicity here. Hyperreflective deposits in the intraretinal. That indicates really inflammatory element more than anti-VEGF drive here in his case. So I think if you want to go further and improve it, you might need to insert some sort of steroid in his eye, Ozurdex.
Okay, Hassan.
Yeah, for me, there's the central retinal thickness is normal, and there is just exudate. Just I said I will observe the patient. But if there's any parafoveal, maybe I will add some focal laser after this 6-month injection. If there is no just normal central thickness, I will not give anything more.
Okay. Actually, I want to tell about this one. So I didn't mention everything about the patient because I was anticipate to ask me about all these things. First of all, I found this patient, he is not having any, correcting, or the diabetes is not controlled. And I think it was hemoglobin A1C above 13 or 14. So at the same time, I'm giving the treatment. I was insisting of controlling his diabetes, and now he is around 7 something, 7 hemoglobin A1C, the last test. Also, he is hypertensive, high lipid profile. So all these measures we try also at the same time to control the systemic problem that may participate or add a burden on diabetic macular edema or cause macular edema in addition to diabetes, or to control the diabetes mellitus. The other things, I think, sometimes we don't want to give a feed up from, first 2 or 3 injection, because after the 3rd injection, I feel the edema is increasing again, and even the patient, he was, the vision almost, we can say he improved nicely and he didn't deteriorate. Regarding the ischemic changes, we have done, I didn't do actually a fluorescein angiography because it was not available to do. But I feel we are following the patients, and I think I will take I don't know, I have decided to give him one Ozurdex injection after a while to see, because now this is the maximum improvement that we achieve after the 7 injection. I will wait, not immediately. I will wait, for example, 1 or 2 months. If he is well controlled and in the same way, so I will not do anything. But if he is start deteriorating, maybe I will give steroid and see, maybe we can have more chance to improve the visual acuity. This is my comment. If there is any other comments from other colleagues, Dr. Fahad, if you are with us, or Tariq or Hassan,
I think Muhammad, if you have a proper fluorescein angiography and you have a look,
yes, it will be more.
You have a look in the peripheral retina.
Yes.
I think these patients, depending on your history of really bad metabolic control, high lipid profile, A1C up high in the sky, you might need to give him in the near future a gentle peripheral PRP
laser,
as well.
But this patient was having, I will interrupt you. He was exposed to actually PRP. He's having a PRP before somewhere, and that's why it's not in my plan. Already he is having PRP in both eye. Actually, I present this one because at the same time I have treat the other eye with steroid immediately, directly, and we are having a very good also result in the other eye. That's why, but I share here because we are talking about as an anti-VEGF rule of management, even of diabetic retinopathy, not only diabetic macular edema.
Just can you explain for us how it will respond for the edema? Because for us here, the anti-VEGFs, as we see, the oxidate is around the large vessels, not just in the central, just like microaneurysms.
No.
So the for the anti-VEGF is tilted the eye as a whole. So as a steroid, it was the response is the same, or just because the oxidates here, mostly if even resolved, mostly the vision will be kept in the same around because already the photoreceptor is affected by this lipid.
In the center,
In the center. So for us, As the vision was around the same, the improvement, or no, there is difference? Which better was, the anti-VEGF or the steroid? Just for us to know.
Actually, we cannot give a judgment from one case. We have several cases. Actually, I'm trying to find this one, but I didn't gather and do analytic way that we can answer the question. But for the same patient, yes, he improved also in the other eye. And he is having also a good visual acuity, but you mean there is a less burden of giving more injection. This is the only things I can say. But is it the same exactly or not? The visual acuity improve, or we can say almost similar, 0.25, this one 0.3, the other one 0.25, 0.8, 0.28, sorry. The central, the edema also improve, the exudate also improve. But I cannot judge if any one of them is better or not. Maybe if we just collect several cases and do the comparison, it will be more, we can have, a good indication or reply, for the question you asked, Dr. Hassan. If you have any things related to that, maybe you can highlight this point.
Not just because for the anti-VEGF, mostly there is a rule to decrease the diabetic retinopathy as overall, mostly more than 2 steps according to the studies. About the steroid, there is evidence, but not as comparable. If you compare it to the anti-VEGF, the anti-VEGF is better than the steroid.
Sometimes I don't know if I do remember or not exactly, but also there is something about especially the Ozurdex, they are talking about if you give after several injection, you will find the resolutions of exudate. I'm not talking about the central one, the one which is not almost central. Maybe Dr. Fahad, if you can hear us, he can highlight about this point. He is having a good experience about difference between the effect of steroid and anti-VEGF in treating the diabetic retinopathy, especially the exudate in the macula.
Yeah, just to make 2 comments. I do, obviously, steroids I think are better for lipids and for a maculopathy that has lots of lipid involvement, then I think steroids are better. Although having said that, I think you've done remarkably well with this case, even with your anti-VEGF. As to the comment about whether anti-VEGF is better than steroid in reducing 2-step progression, in getting 2-step improvement, I think that is probably true. But having said that, I still think steroids are just as good, because what you've got to remember, if you take the cytokine levels of a diabetic eye and you compare mild non-proliferative with proliferative or severe non-proliferative, actually the anti-VEGF levels are very similar in those eyes. But what increases over time is the inflammatory mediators. So actually, you'd be amazed how good steroid is in reducing 2-step progression or improving the retinopathy. Where I think anti-VEGF is definitely superior, and where I personally am very keen, where I prefer it, over, for the treatment of diabetic macular edema, is if I have a patient with proliferative diabetic retinopathy and diabetic macular edema, I would probably want to give anti-VEGF first to resolve their diabetic macular edema, regress their proliferative diabetic retinopathy, and then add in my laser to stabilize and maintain regression of the proliferative diabetic retinopathy. Just because I think anti-VEGF are better when it's proliferative. However, if I have an eye with diabetic macular edema and there's a pre-proliferative retinopathy, then to be honest with you, I will decide, depending on the patient factors, whether I'll go for anti-VEGF or steroid. Some patients are more suitable to anti-VEGF. They're phakic, they've got a clear lens, they're younger, they're able to come to hospital more frequently. But you may have a patient who can't come to hospital as frequently, or they're pseudophakic, or they have recent heart attack or stroke. So you want them to avoid anti-VEGF. And to be honest with you, I don't think about the retinopathy regression. It's not a factor that makes that changes my thinking, because in my mind, steroids and anti-VEGF will deal with the peripheral retinopathy just as well. What you've got to think about is laser. That's the thing that's going to give you the long-term resolution. We need to avoid using intravitreal therapy for treating non-proliferative retinopathy. I think laser is what's going to give you the long-term regression, because if that patient has an interruption of their intravitreal therapy, then you have the laser to maintain regression of their diabetic retinopathy and to stop severe sight loss changes developing.
Okay, thank you, Fahad. Actually, this patient is not proliferative diabetic retinopathy. He is severe non-proliferative diabetic retinopathy. Anyway, I think we take a time for discussing my case. So I think it's now the time to have Dr. Hassan, and let us see what he prepared for us as unusual presentation, medical retinal presentation.
First, good evening, everyone, and I hope that I will present one case for us. Maybe most of my friends know about the case. So first, let me thank Dr. Mohammed the chance to speak through the MEOM platform, and I want to thank even Bayer team for sponsoring this lecture. As all of us that we know that diabetic mellitus is increase in incidence, and for that there is increase in incidence of diabetic retinopathy, which will affect the vision, and mostly in the person who is in the working age. And as according to the mechanism of the action of this disease is hypoxia, and will cause vascular permeability, inflammation, and nevascularization. And by blocking, by know about these factors and how affect the receptors, and blocking these factors, maybe we can stop this cascade of leakage and inflammation and nevascularization, and decrease the macular edema. And as the role of the placental growth factor and vascular endothelial growth factor is level in the diabetic retinopathy is approved, and through the studies, and there is increase in these two levels of these materials. Blocking these materials will at least give us the treatment, as all of us know that we have 3 label medication to use, the aflibercept and ranibizumab and bevacizumab, and we know the difference between them, and how the aflibercept is it was to have the innovation to treat the multifactorial of the mechanism of diabetic retinopathy by blocking the BGF and blocking even the VEGF. And through the Vivid Vista, which was the first trial which approved the rule of aflibercept in treatment of diabetic retinopathy, which give us the rule of the first 5 loading dose, and even given us about durability of this medication, how it's comparing between two time of injection that use the aflibercept monthly and they use it every 8 weeks, and was the result was around the same. This is give us the chance to have more durable medication if we use it through every 8 weeks, and it was the same number of letters which will gain through the first year, after even the second year, comparing by the laser. And here we can find that after the 5 loading dose, we reach the 90% of the number of letters which will be got in the end of the first year when we use it as every 8 weeks after the 5 loading dose. And when we compare it by Rise and Ride, which was done by ranibizumab, which compared by the laser, it was monthly injection until reaching this number of letters when we compare it by the every 8 weeks from the Vivid Vista. And I want also to take just to refresh our knowledge about that the study Protocol T from the RCR, which comparing between 3 these medication head-to-head by aflibercept and ranibizumab and Avastin. And we reached that the patient has vision less than between 20/30 and 20/40, all the medication around the same. And if the patient is less than 20/40, the aflibercept has a priority on against ranibizumab and bevacizumab in the first year, and which was extended comparing to the bevacizumab for the second year. And through that, the European guidelines was giving give the aflibercept to be the drug of choice for the patient who has diabetic retinal macular edema, with vision less than 20/40. So I want just to highlight some cases which will face it in the clinic, as this patient who is 60 years old, diabetic, type 2 diabetic mellitus. The patient has vision around 20/40. So I can see that the exudates, and the patient received, we put the plan for the loading dose, and from the second injection you can see that a good response. The retinal thickness is good, as the vision still didn't reach the V1. So we kept giving the patient aflibercept until finishing the loading dose and evaluation. But sadly, this is not the situation always. Sometimes we face cases, as this patient who is 69 years old, diabetic mellitus. The patient pseudophakic. The patient was not severe non-BDR with macular edema. On 2015 December, he developed the acute retinal necrosis related for herpes zoster, which we treated by surgery outside, and the patient has oil, and the patient depending on the other eye. And the patient, since 2016, when he just developed drop of vision, the vision ones become 0.9. We suggested him to go for the ranibizumab 3 injection. But the patient, after 3 injection, you can see that there is no improvement in vision, and there is an increment in the central retinal thickness. So here we just suggest to switch the patient for the aflibercept. It was done in the private, and when the patient underwent even focal laser and BRB. But the patient, after the 3 aflibercept, you can see the patient still the cyst is there. There is the central retinal thickness around, is the decrement in this CRT is not so much as we expected. So the patient came back for us. We did for him fluorescein angiography. You can see there is still the situation of the diabetic retinopathy that's around the same, severe, and there is macular edema, subretinal fluid. So we suggest for the patient to go for aflibercept, and we add for him micropulse laser, as the patient is refusing receiving the Ozurdex, and for us as the single eye, so we consider to continue by the anti-VEGF. So after three aflibercept and micropulse laser, you can see the vision is 0.7, and there is a weak response or poor response for us. The CRT still is around 500. So for us, as we discussed with the patient, and you know that this patient, when he's single eye, you can't convince him that you can go for the steroid, especially if he has any history of losing the other eye by viral infection, and still the glaucoma, there is risk for him. So here we give the patient an extra 3 aflibercept injection, and you can see the response here. There is response, but the vision didn't improve. But there is a decrease, but not as we expected after this number of the injection. So the patient here concerned about that there is no improvement in the vision, in spite of there is little decrease in the CR, in the central retinal thickness. So here we decide for the patient, just as there we discuss with the infectious disease specialist and immunologist, and we discuss with some colleagues, maybe some of you know about this case, that there is no chance for him. Maybe he will, even there is risk, maybe he will develop the acute the necrosis in the other eye if he received the Ozurdex. So there is no guarantee that we can prevent this from happening. So we suggest the patient, as there is decrease in the retinal thickness and there is no improvement in the vision, we can go for monthly injection to see how is the situation, and we will keep observing monthly. So since around May 2019, he received monthly injection until, and you can see here, we evaluate him monthly, and there is a very weak response. You can see that the decrease in the CRT is just around 15, 20, 30. So when we reach here, when that was the patient reaching is before the epidemic, the vision was 1, and there is the resolving of the cyst, and even the central retinal thickness is 400. And here the patient decided to stop, as he is just received this number of the injection, and he wanted to go for the BRN and keep follow up as regular. So from this case, that we found that there is not all the patients for us, they have the good response from the first loading dose. There is some patient, maybe even after 3 years of injections, there is kind of response. Maybe in this patient, we didn't use the steroid because of his systemic issue, but the VGF was a solution for him when we use it as an long-standing treatment plan for him. For us, there is any evidence from the studies. Yes, there is evidence from protocol I and the protocol T that there is kind of patients who can, even after the 24 weeks of treatment, he can even have some response for the anti-VEGF, and it was approved for all the medication, maybe better than aflibercept than Avastin, and it was approved in protocol I, which was using the ranibizumab. And also through that, before the 24 weeks, if we go for the protocol I and the protocol T, you can find the patient who received the intensive primary treatment, which was loading dose. The patient has less chance to keep or to have persistent macular edema, which was approved even in protocol I and the protocol T. And even when the patient is when the patient receiving the first loading dose, he will first even prevent him from receiving more injection, because according to the patient who received protocol I and protocol T, who receiving around 9 injections the first year, he was less than the second year and less than the third year and fourth year in the protocol I. So when they were using the primary treatment for hit the diabetic macular edema, most of the patients will end by less number of injection and will have a high success rate to save him from become as chronic macular edema or persistent macular edema. So just to conclude here, the early intensive treatment is very important, especially in the first year, which will give the chance the patient for maximum number of letters, which will gain the first year, and will prevent him from having chronic macular edema. Aflibercept is the choice for the patient who is less than 20/40, and continue treatment by the anti-VEGF. It's a solution for some patients who has limited early response in diabetic macular edema. And thank you.
Thank you very much, Dr. Hassan. This is a very nice and excellent cases. If there is any question from Dr. Tariq or Dr. Fahad, any of our colleagues participant, anyone also he want either to send a question or in a chat, or he can also raise the hand and he can have a live discussions with our speakers. Okay. Yes, Fahad.
Mohammed, I just wanted to say to Dr. Hassan, I think his caution was very sensible. We've got to realize when you're managing an acute retinal necrosis, we often give the antivirals, to protect that eye, but mainly to spread the contiguous spread of the infection to the fellow eye. So we don't know whether some of that virus tracked, to the other eye, to the contralateral eye, and then, to give an Ozurdex, and we know there are case reports where you've induced an acute retinal necrosis or a syphilis or something like this in an eye with a latent infection. So I think his caution was very, very sensible. And although there hasn't been the ideal anatomical response, and had it not had this complexity, that we would have stopped. We should have, we would have switched to steroid. But in this particular circumstance, with this particular patient, I think his management approach was correct. And one hopes that even if we haven't improved the anatomy, that at least you've stopped his vision getting worse. And, the PRN approach, particularly in year 2 and year 3, is not unreasonable, because we know eyes can tolerate diabetic macular edema. And the key thing is that you intervene when the vision is declined. So it's a long-winded way to say, I think you managed it very sensibly. And I think you were wise not to use steroid in this case.
Okay, Hassan, if you want to have any comments about
first of all, I want to thank Dr. Fahad, and especially Dr. Fahad was aware about this case because we discussed with him maybe 2 years back, because for us, yes, was the problem with the patient is that the patient didn't accept to sacrifice in any chance for risk to develop glaucoma, or has a risk to develop, because there is, as Dr. Fahad reported, that there are some patients receive some steroid injection and they develop the acute necrosis. And as we discussed, as we said, we discussed with an immunologist, and he said there is no guarantee even if you cover him by the antiviral. In this situation, just I think that the message here is there are some patients who has poor response in the first 3 injection. So sometimes we can switch him for the anti-VEGF, but in some circumstances, I think that if you keep the patient strict to the treatment plan, and especially in the first year, maybe when this patient, he was off from treatment because there is no improvement after 3 injection. But when he commit for the plan, we give him from May until March, by monthly injection, the patient was improving slowly, even the vision. And in the end, he reached the 1, and the CRT, the central retinal thickness was good. And why we don't switch him for another medication? Because for us, we try with him before the ranibizumab wasn't any, if it was worsening. So we can't continue by medication when the central retinal thickness there is increasing and there is decreasing in the vision. You should stop it according to all the protocols. We can. So for that, we keep the patient.
I have seen one of the questions, Dr. Hassan, from one of our board. I don't know if you saw that question. Why you don't have alternate? One time is the idea, then the other time Lucentis. Is there any role for giving this way of management, first of all?
Just because for us, if you saw the patient was naive patient and we give him 3 ranibizumab injection, the central retinal thickness was increasing and the vision is around the same. Here we transfer for the aflibercept. At least in the aflibercept wasn't the worsening in the central retinal thickness. At least was stable, maybe. But in the last, the patient was keep improving. But the problem with the patient was after the session of the treatment, when we give him 4 injection of 3 injection, there is no vision improvement. This is which worried him, not the central retinal thickness as we notice on the OCT.
Okay, I think just one question. Would you what about off-label Beovu?
In this patient, available that time maybe.
Yes, but even in this patient, I will not try it because the patient has an infectious
vasculitis, and if you are thinking about this one, it will be also another options of another way of having some complication. One eye, this is the problem. I think the only problem here that we are having a patient, one-eyed patient, and you cannot try or to you will not feel free when you are trying to shift to any other medication that may even in 1% may make him worse. But the question I didn't get an answer from you or Dr. Fahad or Dr. Tariq. Is there any way to, not only in this patient, to alternate? Sometimes you are having one anti-VEGF Eylea, then the next month Lucentis, then after that, if you didn't find, you go. Is there something that you face or you do any this way of treatment?
For me, just if I switch the patient. Generally, I will give him.
No, we are not talking about switch, Doctor. Now the question is clear. I mean, not switching. He is saying alternating, one like this, one maybe because there is no response. One time like this, one time maybe there will be some difference.
Switching between anti-VEGFs, according to the papers, they say that when we switch mostly after 3 consecutive injections, there is no improvement in the vision more than 1 line, and there is the central retinal thickness, there is no improvement more than 10%. Here you can switch, and they depend that there is tachyphylaxis for the anti-VEGFs because these anti-VEGFs are proteins. So there is some sensitivity for that.
If you understand my questions.
I might combine with Ozurdex and an anti-VEGF. Okay. So I have the odd patient where they need like an Ozurdex, and then at 8 to 10 weeks, I give them an anti-VEGF to maximize their macular edema improvement. But I've never alternated between anti-VEGF agents like that. Okay. I use one or the other.
Okay, that's the question, Dr. Hassan. The question is alternating, not only to switch. Okay, I think now it's thank you very much for this, Hassan and Dr. Fahad and Tariq. We can move to either Fahad or Tariq, whatever. If you are Fahad ready, we can go ahead.
I am ready, yes.
Okay, please.
Mohammed, can you see my screen?
Yes, now we can see, yeah.
Again, I'd like to thank you for your kind invitation, and it's always lovely to share my experience with my colleagues from the Gulf, but also to hear your experience as well. So thank you ever so much for this lovely discussion. I just want to share some photic retinal injuries. So this is a 25-year-old Yemeni lady who attends the clinic with a 10 to 12-year history of difficulty reading and other near visual tasks. She has no difficulty with color appreciation. She prefers mesopic or dim illumination with no family history of macular dystrophy, with a visual acuity of 6.9 on the right, 6.12 on the left. I have to say, when I first met her and took the history and examined her, I did think that this lady was most likely had a cone dystrophy. However, her OCT was pretty sorry, her autofluorescence was unremarkable. So it didn't show signs that would meet or fit with a cone dystrophy. And on the OCT, she had these symmetrical defects in the inner segment, out segment junction at both fovea. So I asked her, I said, did you ever stare at the sun? And she said to me, yes. So this was a Yemeni female. And apparently there's a game that Yemeni children play when they're younger. And it's also shared in East African nations as well, in Somalia and Ethiopia, where basically they see who can stare at the sun for longest. And she did this, and she would play this game for as a child, and she would basically stare at the sun, and she always beat the boys. But unfortunately, because of that game, she induced a solar maculopathy. But at least I was able to get a diagnosis and counsel her that unfortunately, there were no treatments I could offer to rehabilitate her vision. She was referred for low vision rehabilitation. But she admitted to staring at the sun as a game during childhood. Inshallah, Muhammad never used to play that game when he was younger. Anyway, photic retinal injuries occur when light is absorbed by the retinal tissue chromophores. So we have many chromophores in the retina: the melanin, hemoglobin, lipofuscin, and optical radiation includes the bandwidth of 400, 700 nanometers, which is the visible light. The shorter ultraviolet light is absorbed by the cornea and crystalline lens. However, other wavelengths can, be transmitted into the eye, causing harm to the retina. And the mechanisms of photic retinal injury include photodisruption, photochemical, and photothermal. So I'll first start with photodisruption injuries. And the definition is it's a retinal hemorrhage or retinal hole. The sort of photodisruption injury tends to manifest in that way. And it occurs in YAG laser capsulotomy or high-powered blue laser pens, where the laser ionizes the target tissue molecule and it produces plasma, and the rapidly expanding shock wave dissects the target tissue. So this is an 11-year-old boy with an acute blue laser pen injury. And because he misused the blue handheld laser pen bought from the internet, he shone it into his eye, and his visual acuity had dropped to 20/300 with a small full thickness macular hole. So that rapid distensional swelling of the retinal tissue caused a disruption in the center of the fovea. The hole enlarged over the next 2 months, requiring a vitrectomy with ILM peel, with the vision improving, unfortunately, only to 20/160 postoperatively. This is a patient with a suspected YAG laser injury. So it's a 55-year-old hypermetrope who was referred from a neighboring unit in the here in South Yorkshire. And he undergoes YAG laser iridotomy. And the patient was aware of a blind spot in the left vision immediately after the YAG laser treatment. His visual acuity was 636 in the left eye, and he's referred to me for a second opinion. And as you can see, there's a change at the RPE juxtafoveal in that left eye. On the OCT, there is some disruption of the inner segment outer segment junction with some intraretinal cysts or intraretinal atrophy. And then there's a space as well, or an area of subretinal fluid, or just basically missing retina exactly over that RPE change with transmission of the infrared light through the into the choroid. And as you can see on autofluorescence, that RPE is completely missing with a large hyperfluorescent defect. So from my perspective, this was a YAG laser injury. I'm not sure how the doctor did it, but somehow by trying to do the YAG laser iridotomy, some of that YAG laser was transmitted and it induced a retinal burn. And the main reason is because the patient, there was a strong temporal relationship between the laser treatment and the onset of the symptoms. So when you diagnose a laser injury, it's important that you know the light source, that you can see evidence of chororetinal damage, like in this case, that there is an unambiguous relationship in time between the laser incident and the onset of serious visual symptoms, and the severity of the visual symptoms is commensurate with the extent of the retinal damage demonstrable on retinal imaging and examination. And finally, that you see some healing or chororetinal modeling after the laser injury. Photochemical injuries, this is defined as yellow-white foveal or extrafoveal lesions, and they occur because the chororetinal temperature elevations are too low to cause photothermal damage, like in a laser pen injury, but the illuminances far exceed the normal environmental levels. So the light is much brighter than you expect in normal environmental levels. And the exposures can be anything between seconds to minutes, and optical radiation or solar radiation can produce highly active oxygen radicals, can then damage the retinal cell membranes, proteins and carbohydrates, and as well as the nucleic acids. UV radiation is the most harmful, and it's similar to the absorption spectrum of lipofuscin in the RPE. And so highly phototoxic UV radiation, so welding arc radiation may be transmitted into the retina, causing a welding arc maculopathy. And basically the light is so bright that it excites the retina so much that it produces a lot of free radicals, causing a toxic reaction at the retina, but you're not actually heating the retina. So it's not a thermal injury, it's a photochemical injury. And photic injuries include solar maculopathy and arc welding maculopathy. So solar maculopathy is like the case of that Yemeni lady. So momentary solar observation is safe, but prolonged solar observation is a risk factor. And direct solar observation with a 3 millimeter pupil only raises the retinal temperature by 4 centigrade. So typical solar maculopathy is photochemical, not photothermal. But if you have a dilated pupil at 7 millimeters, actually that can heat the retina up to 22 centigrade, well above the 10 centigrade threshold needed for retinal photocoagulation. So it's important that our patients who attend our retinal clinics, we advise them not to stare at the sun after pupil dilation. But solar eclipse observation is the most hazardous because pupillary dilatation can occur, increasing retinal irradiance, increasing your risk of solar maculopathy, which is why we should never stare in eclipse, because we're able to then stare at the sun, stare at that UV light for longer periods of time, inducing a photochemical injury. So what are the risk factors to solar maculopathy? Hyperglycemia, drug abuse, psychosis, or this sun gazing game, which is very common in Yemen and East Africa, and as well as religious rituals. I have seen a few cannabis users where, because they're high, they started to stare at the sun much more than they should, inducing a solar maculopathy. And people with darker chororetinal pigmentation are at greater risk. And just to remind everybody, sunglasses are not safe for sun gazing, and pupil dilatation potentially is associated with an increased risk of solar injury. This is a 45, I've got another case here. This is a 45-year-old male, fit and well, presents to his optometrist with a reduced vision in his left eye of about 2 weeks, and he presents with a disc-like lesion in his central vision. His vision is 6.4 in the right, 6.36 left. This is his color photographs on OCT. So as you can see, the right fundus is completely healthy. In the left eye, he has this disc-like lesion of chororetinal damage at the level of the RPE, just outside the fovea. And as you can see, there's an interruption of the outer retinal layers in that area of RPE change, with increased transmission of light into the choroid. About a month later, there's very little improvement in that change. I asked him, did he misuse any laser pens? Has he been staring at the sun? Has he been welding? He goes, you know what? I don't weld, but I run an engineering company where welding does happen. And he came back to the next appointment and he found this video.
Which one of them?
I think the white one, the one who
Both
wearing
white.
a white, the right white. Yeah, I think just this. Could it be only this? In 1 second, he just looked to the.
Let's say the younger chap. And the guy with the glasses.
Okay, Fahad, which one? You are
This is the
mute,
question.
Fahad. Fahad? Hello, Fahad, can you hear me? You are mute.
Is he mute or
Yeah.
cannot hear us?
Fahad, we cannot hear you. Hello. Okay, can you unmute Dr. Fahad, Doctora? Hello, Doctora, can you unmute Dr. Fahad?
هو يفتح يا دكتور، انا بعمل له بس هو يعمل اكسبت.
ما هو لا، هو مش aware ان احنا نتكلم معه. Dr. Fahad, if you can hear us, we are not hearing you. You are mute, please.
Very rare to have a maculopathy from arc radiation.
Okay, he is still continuing. So can we stop the share so he can understand that he is not? Okay, stop the share.
Visible, Afwan.
Fahad, we are not hearing you. No,
Really?
no. Yeah, you are muted. That's why we stop share. So you can go back from the time you play the video. When you start playing the video, after that we didn't hear anything.
Okay. So do we need to watch the video again, or should I just?
Yeah, go from after the video. Just we ask you who is the one was having who's one of them? Which of them he was having the problem of welding?
So the second case, I'll show you the case that was the welding arc, and I'll skip the video. Okay.
No, we are asking about the video. There is two guys. Which one of them?
It's the one who is the second one, the one who is walking away.
Okay, the glasses, yeah.
Okay.
The one with the glasses walking away.
Yeah. Oh. Did you check the second guy as well? Maybe he had a.
No,
he didn't come.
I never checked him. I just saw the patient who came to me. No, let me go back. Sorry guys, I've just got we're nearly there, so I'll just start again. Can you see my screen?
Yes, we are. Yeah, we can see. Just if you can go, yeah.
Going now, inshallah, bismillah. Okay. back to 26.
So go directly to the video, please, and from the after the
Perfect.
videos. Okay.
Okay. So in this particular case, it was a type of welding arc maculopathy called metal inert gas arc maculopathy. So what happens is they use some argon gas to insulate the electrical charge, but this produces a very intense illuminance that's maximally absorbed by the eye. So it irradiates all that energy at the macula, and it basically excites the retina so much, those rhodopsin and the other the rhodopsin chemicals, and you get such a high amount of free radical formation that it then induces an injury without actually heating the retina. So be very cautious of. So whenever you see any unexplained RPE change, I always ask about solar maculopathy, laser maculopathy, and welding.
Fahad, just one question. I mean,
No problem.
from 1 second, just a few seconds that when you saw the video, he is only a second. I mean, he looked to that.
It's a very brief illumination. So you have a very healthy respect for laser pens, and have a very healthy respect for. But yeah, I mean, it was the briefest of illuminations. And what I'll do at the end, I'll play the video again, and then I'll stop share the screen, and then I'll stop sharing, and hopefully you can still hear me. But it was not even a second, not even a second.
Okay.
And then the last injury that we're very familiar with is photothermal, and where you get photocoagulation burns that are visible with your eyes, or with ophthalmoscopy. Those are your typical laser burns, and they occur because you get intense light, which is absorbed by the melanin. That light is then converted into heat, and that then increases the temperature of the exposed pigmented tissues, and then causes overlying neuroretinal damage. And standard clinical photocoagulation, like we do in PRP, increases the retinal temperature by 20 centigrade. And this is an
Muhammad?
Okay. We are having again. Fahad, you are muted.
Muted, yeah.
Okay. Can you stop share again?
shining is it still not
No, you go again to be careful of I think you are by mistake you are doing us mute. You are muted yourself. So we are videos, we are not hearing your comment.
What I'm gonna do is every time I show a video, I'll stop and share again.
Okay. Yeah, maybe. Okay.
Yeah, sorry about this, guys.
No, but on the I mean, I know you are using an iPhone, right?
I am using an iPhone, yes.
That's why after every time you are playing, just go and unmute yourself. That's it.
I've done it now. Share. I've done share audio as well.
Okay.
So inshallah, this will work. So this is somebody.
You are mute again. Fahad, if you can hear us, you are muted also. Okay, I think we need just here to stop share.
Mohammed, can you hear me?
No, Fahad, all the times about the videos you are having a problem, I think, with the okay.
No, that's fine. So there's no more videos. So what I'm gonna share my presentation again in a minute. But the point I wanted to make is this is a very good video and I'm sorry you can't see it, but basically there was an experiment they did for an Australian news channel where they shined a safe laser pointer, which is an output of less than 1 milliwatt. So please, brothers and sisters, do not buy laser pointers for online. If you need to buy a laser pointer for a presentation, because you want to teach students or whatever, and you want to highlight things, buy it from a reputable seller and make sure it meets the safety requirements of 1 milliwatt. If you shine a safe laser pointer on a balloon, you cannot burst it. But if you shine a laser pointer, if you buy a laser pointer online, it may say it's 1 milliwatt, but actually it can be anything between 30 to 100 milliwatts. And if you shine that on a balloon, it will cause it to burst. So after this, I stopped buying laser pointers for my talks. I now, if I want to show a presentation, I use my phone or I use my watch, but I do not, or I point. I've stopped using laser pointers. But if you really have to buy one because you want to educate students, then buy it from a reputable bricks and mortar building, which meets safety regulations. Otherwise, be careful buying a laser pen online. They do lie, and they will sell you. They'll say it's safe, but actually, if you shine that in your eye, it will induce a laser burn. So I'm going to share my presentation again, and we're nearly finished, inshallah.
Okay, we have 2 minutes. If I had to finalize.
I'm going to keep it very brief then. Thank you, Muhammad. So just to say, this is a patient of self-harm. He got a laser pointer, shined it in his eye, and he managed to reduce his vision to 660. You can see the interruption in the fovea due to the intense laser burn, and in both eyes. And look at the intense hyperfluorescence. So if you see a foveal, a very demarcated change in the fovea with very poor vision or intense hyperfluorescence, think, could this be a laser burn? He didn't admit it in the beginning, but then he later admitted to misusing a laser pen. And unfortunately, he's now registered blind. We've not been able to recover his vision. And very lastly, very quickly, this was a young boy, 9 years old, whose father bought him laser pen as a Christmas gift. He bought it online. Obviously, he's a young boy. What do young boys do? They take the laser pen and shine it in their eye. This is what this boy did. And he induced a laser burn at the fovea. And when alhamdulillah, we saw him quickly within a few hours. So we started him on oral steroid. However, when we confiscated the laser and we tested it, it was between 40 to 70 milliwatts. So 40 to 70 times more powerful than it should be for a consumer laser pen. And yet the label said 1 milliwatt. So the seller was deceiving the consumer. So be very careful about laser pens online. And this was his fovea at presentation. So you've got this yellow burn at the fovea with this very well demarcated hyperreflective changes within the fovea in almost like a column. And like I said, we treated him with steroid, and alhamdulillah, he recovered his vision to 6.6. I will stop there. Okay. Stop share. Thank you.
Okay, thank you very much, Fahad. This is an excellent presentation as usual. Very nice, unusual retinal or medical problem. So we all the times, talking about diabetic macular edema, AMD. So we want to highlight another a very important issue that you are highlighting. And I think most of, everywhere they are having this, especially the laser, pin laser, and that may lead to blindness for nothing. I mean, just you are bringing to place him, then you are just harm your children or whatever. Is there any question to Dr. Fahad about this one, or Dr. Tariq? I think.
So Fahad, thank you for the presentations. This was really, really good. I mean, do you recommend oral steroids for this type of laser maculopathy? I mean, do
so
they really work and recover
yes,
the vision?
yeah, I do. There's two things I want to make, points I want to make. I think it depends how acute the laser burn is. How soon did they see you after the presentation? If it's a few weeks after or a few days after, and already now it looks like a retinal laser burn, like a PRP burn, then it's probably, at that point it's too late. But if it's still very fresh, so the retina is white or yellow, and there's still some hyperreflective changes at the macula, then I think there's no harm in giving steroid. That's all you can do in the hope that steroid will reduce the amount of retinal edema. I think, to me, though, the two prognostic signs are the presenting acuity. If the presenting acuity is very poor, or there's very intense hyperfluorescence on the blue laser fundus autofluorescence, then I think the prognosis is very good, and it's important you share that with the patient. But there's no harm. And what I do is I give 40 milligrams for about 3 or 4 days and then taper it over 2 weeks.
Right, okay.
And what you find, you get a rapid resolution. And then after about a month or so, it starts looking like macular laser burns, true laser burns.
Yeah, I always think about empirical treatment with the steroid, but I never thought about that it might make a huge difference, like in your case, to be honest.
Yeah, no, I think you have nothing to lose, and at least you're doing something.
Yeah.
Okay, I have one question there in a chat. Yeah, okay, if you saw it, so I was planning to read that questions. If there is, ophthalmic laser room, if you are doing a laser, either YAG or argon laser, and there is someone not wearing the goggles, is it effective, and how is that effective?
Yeah, I think you've got to be very, very careful with your laser safety. You as the doctor aren't particularly at risk because where you're sat, the patient isn't particularly, the other eye of that patient isn't at risk because of the way the light bends. But if there's anybody else in the room, there is a very high risk that they could get a laser injury. So it's really important for laser safety that if you are doing PRP, that if there's any nurse with you in the room or in the OR, that they wear laser safety goggles.
Fahad, do you mean for the patient, you are doing one eye, you have to close the other eye?
No, I don't close the other eye because the patient, I've never yet induced it in a patient because of the angle. You're safe and the patient is safe, but any bystanders are not safe.
Okay. Any comment about maculopathy induced by macroscope? I mean, operation goes for.
Yeah, you know what? I think it does exist. I haven't seen it, but I know there are case reports. Yes.
Yeah.
So as a principle, I always like during how it is you operate, and the nurse is taking their time doing something. I'm always covering the eye, so I'm only allowing light to be in the eye if I'm doing something.
Right. Yeah. You have the small sponge.
Okay, thank you very much, Shahad. It was an excellent presentation, discussions, and knowledge. Thanks a lot. We can now move to the last presentation by our dear colleagues, Dr. Tariq. If you can share a screen. So
1 second, Dr. Muhammad.
Who is this Ninga?
Share, start broadcasting. Can you see my presentation?
We can see only, no. You are going and coming, no.
No?
No.
Share screen.
Okay, you are sharing now. Okay, you can select now your topic.
Okay. Thank you, Dr. Muhammad, for inviting me.
We cannot see now until now. We are seeing only a white. If you didn't select the okay, now yes. Okay.
Can you see it?
Yes.
Sorry about me. This has gone back. Thank you, Dr. Muhammad, for inviting me to talk today about unusual maculopathy. This gentleman He's a 50 years old gentleman referred from the optician for deterioration of both distance and near vision. He had described a progressive dimness and blurring of vision in both eyes. Previously, with the optician, his vision has been recorded normal at 6.5 bilaterally. There was no significant ophthalmic history, and he had no prior ocular or relevant family history. The only positive history, the patient was a night clubber. On examination, his vision in the right eye was 6.12 and the left eye 6/9.5. There was no anterior, no relative afferent pupillary defect, and bilaterally anterior segment normal. And we'll go now forward to see his retinal images here. I mean, if you can appreciate it from your side here, the small tiny lesion, yellow lesion bilaterally right and left. As you can see, both in the fovea bilaterally. And just quickly goes back to the anatomy of OCT anatomy of the macula. So we can see here the ellipsoid zone, the external limiting membrane, and then we go back to our patient OCT, as you can see here by Heidelberg, spectral domain Heidelberg. OCT, as you can see, this is a vitelliform lesion here affecting, there's hyperreflective lesion in the shape of vitelliform, and it's causing disruption or interruption of the elliptical or ellipsoid zone and extending up to the internal limiting membrane. 1 month later, he had resolution of his symptoms, but I mean, definitely his anatomy hasn't changed on the OCT. His vision has improved in the right eye from 6.12 or over 6.5. So he is bilaterally now 6/9.5. Autofluorescence didn't show any abnormality, unremarkable bilaterally. Also the fluorescein angiography. So a few months later, the same pathology, vitelliform-like lesion, as you can see bilaterally here, affecting the ellipsoid zone. Patient symptoms has relieved, but his anatomical changes hasn't improved a lot. So any thoughts here from
Assalamu alaikum, Tariq. Well, this is a really good case. Did he misuse poppers?
Yes, spot on.
Yeah. So
yeah,
I
should have excluded you.
We want to keep it to the end. We want to keep it to the end, Fahad. You destroy.
Sorry.
Yeah, it's okay.
Okay. So start again.
Right.
Any family history of eye problems? So the thing is any family history of eye problems? That's the first question.
Yeah.
I'd want to know, because it could be bests.
Exactly. Yeah. There's no any family history. Yeah. Or
any laser injury? Is he Yemeni? Is he sun gazing?
Why all Yemenis? Why all the Yemenis, Fahad? Why all Yemenis? It can be even British, my dear. Okay.
Yeah, he was pure English, Caucasian, you know.
So the other one is the other one is whether they've misused poppers.
Yes.
But I think the differential is poppers, cone dystrophy, bests, laser, solar.
Yeah.
Those
exactly.
are the things I'm thinking.
Completely agree with you. Yeah. So poppers is a recreational substance of abuse belonging to alkyl nitrate family of compounds. It has been sold in small bottles and consumed by inhalation. It's also sold as air fresheners and have been popular since 1970s. And there is a widespread use of drugs, especially in nightclubbing communities. Inhalation of these fumes of this nitric oxide donors provide a brief sensation of euphoria, relaxation, and analgesia. And suppliers of such products are not regulated in terms of quality control and health-related toxicity, and are not subject to any narcotic drug regulations. So they has been considered even in UK at a low risk to physical and mental health. And they are available, of course, to purchase online in nightclubs and high street shops. In UK, it was legal to purchase them, but illegal to sell it for human consumption. And the Dangerous Substance and Preparation Regulation 2006 reclassified isobutyl nitrate, which was originally used to manufacture it, as a class 2 carcinogenic. So they have replaced with isopropyl nitrate, and was substituted for isopropyl nitrate due to legislation changes. Since then, there have been several reports of new forms of visual loss termed Popper maculopathy. And this is how does it look if somebody's interested. Clinically, clinically, the first report of Popper-induced maculopathy was documented by Peace et al. In 2004, and actually symptoms start immediately within 2 hours after drug abuse and consist of mostly bilateral visual loss, scotomas, central scotomas, and glare. In one study, the median duration of Popper's use has been between range was 9.8 years, but it can be 1 day to 25 years. Fundoscopy findings can be very, very subtle. You can say normal fundus appearance with some striking changes seen in optical topography. So there's out of proportion between the symptoms of the patient and the findings in the OCT actually in such cases. Toxic maculopathy due to consumption of poppers is an important differential diagnosis in acute visual loss without clinic morphological correlation. Complete recovery of visual functions and morphological and macromorphology is rare, has been reported, but is rare, even after cessation of the drug use. There was one case report when the patient claimed to have used the drug only once, and he had a full visual loss. So I presume it's dose-related outcome. There's individual vulnerability. There was 2 case reports of 2 patients who not only developed characteristic maculopathy, but following Popper consumption, but additionally they show decline in full field ERG, and it has raised the question: is it maculopathy or even extend periphery and involve the roads, not the cones only? And some people name it Popper's retinopathy. The underlying pathophysiology, it's similar to photic injury, with nitric oxide increasing the photosensitivity of the photoreceptors. The second theory is nitric oxide is a potent vasodilator and can cause acute changes in nuclear perfusion pressure and produce photoreceptors injury. Despite decades of abuse, the majority of Popper's consumers were symptomatic, and I think the reason of the outbreak between 2012 and 16 was referred due to the increase of use of Poppers in the population and the availability of more powerful brands of this substance, or even to improvement in retinal imaging techniques like spectral domain OCT. It's possible that failure to inquire about recreational substance inhalation in patients with maculopathy may have led to the condition being missed. So ophthalmologists should ask patients with unexplained foveal yellow spots or outer lamellar macular changes in OCT about inhalation of Poppers. And the recent changes, as we've seen, from isobutynyl to isopropyl compounds may be responsible about the recent recognition of this maculopathy despite decades of popular use of the Poppers. It's important to recognize this is a potential cause of visual loss because it might be easily missed in patient history when specific inquiry is not really performed. So this is a couple of cases has been reported since up to 2016 actually. And as Fahad mentioned, differential diagnosis is really, really important here, but definitely thorough clinical history, it can lead you simply to the correct diagnosis. And in the case of Fahad, when he asked the Yemeni lady about sun gazing, sorry. So on the top of the list is solar or Welder's maculopathy, recreational laser retinopathy, juxtafoveal macular telangiectasia, VMT, closed macular hole, acute retinal pigment epitheliitis, Stargardt, and atypical optic neuritis, because definitely you don't see much of changes in the retina and the initial examination. So we all know about adult onset vitelliform maculopathy. It shares the same vitelliform lesion here involving the subfoveal area, but it does involve middle to old age presentation, and usually doesn't really make much change in the vision, doesn't really cause a dramatic drop in the vision. Pattern dystrophy due to lipofuscin deposition at the retinal pigment epithelium, and you can see in the OCT similar changes in the EZ structure. Solar maculopathy, Fahad has explained fully and perfectly about different types of solar maculopathy and photic maculopathy as well, or retinopathy. Juxtafoveal macular telangiectasia, mainly ladies, diabetic patient with the characteristic features on the OCT. You can see the loss of parafoveal retinal transparency on fundus photo, plus the empty cysts and the external limiting membrane drape, which is quite characteristic to telangiectasia. Tamoxifen retinopathy with a history of breast cancer as well. You can see the crystalline deposition around the foveal area. Acute retinal pigment epitheliitis, self-limiting disease. It happens between 16 to 40 years old. The etiology is unknown actually, and there's no any therapy recommended, but it does cause similar changes. If you can see in the OCT in the bottom right side here, you can see the disruption or interruption of the EZ line. Stargardt differently, fundus flaviomaculatus, quite characteristic here. OCT changes, you can see complete damage of that area EZ line. Thank you.
Thank you very much, Dr. Tariq. This is an excellent and additions to our talks today with Dr. Fahad, Dr. Hassan. It was a great talk. If there is any comment or question before we close this session, was a very interesting and let's say one of the best sessions, and could be the one the last of the last year, the last of the year. So any comment, Dr. Fahad or Dr. Hassan?
No, I think the only comment is that although as medical retina specialists or as retina specialists, we have a lot of bread and butter, but when something doesn't make sense or when it's unusual, remember that we're doctors and just take your time, ask the history and create an environment where the patient is able to share with you something that's quite embarrassing, like taking drugs or whatever. At the end of the day, we want to know so we can make the diagnosis, so we can offer a good prognosis. And I think, the good thing about Tariq's case was that, had he not got that particular information, the patient may have ended up with lots of unnecessary investigation, but at least because you've got that drug misuse history, you're able to then say, yep, this is poppers, and you end the investigation there. So it's really important in the retina clinic just to remember that about 10% of our cases will be out of the ordinary, and it'd be nice, don't be afraid to ask, do a systemic inquiry, but also ask some of those embarrassing questions to achieve the diagnosis.
Exactly.
Thank you, Hassan.
I want to thank you, Dr. Muhammad, and just as Dr. Fahad and Dr. Tariq mentioned, that when we have something is sudden bilateral foveal lesions, we should first just check about the medications, any something acute happen for the patient, because mostly if there is any foveal or parafoveal lesions, most it will be the first for us maybe toxic by phototoxic one or drug related one. So this is why I wanted to mention that bilateral issues.
Thank you, Hassan. Okay, Tariq, your last things, if you want to say something before we close. Just before that, Tariq, can we ask, management, if you can please put the link in the chat, so all the panelists. Okay, nice. So from the MR Vision to all panelists, the link now available in the chat if anyone want to get the certificate of attendance. Yes, Tariq, if you can hear me.
Yes, I can, Muhammad, yeah.
Okay, is there any comment before we close?
No, it's just, as both our colleagues mentioned that, you need to have a low threshold as well to do OCT. You see a lot of these patients who come with a tiny change in the vision, scotoma, and sometimes you have to look and say, listen, 6/9 vision is still good. You don't have much problem, come back to me in a month or two, let us have a look again. I mean, if the patient has symptoms and the patient even slight decline of his vision, I would incline to do OCT, always. You see a lot of pathology, this is one of them, you know, CSR, another pathology which really can be overlooked by initial or casual fundoscopy, you know. So I mean, you need really to utilize the machine you have in the side room, and you need to use the OCT quite often in such cases, because without the OCT you can't really figure it out. You don't know the diagnosis.
Thank you very much. First of all, I would like to thank our speakers, Dr. Hassan, Dr. Tariq, Dr. Fahad, for their input and their excellent presentation. And I'm happy that the last webinar in this year was done in this way, and presenting something that most of the time we are not aware of it, and we are just, you know, we can have this presentation, and sometimes you will find yourself in a way that you don't know what to do. But if you think, as Dr. Fahad said, you know, and ask some questions even, and dig deep in the asking in the history, maybe you will find the answer for the dilemma that you are for diagnosis of the patient. Also, I'd like to thank Bayer for sponsoring this event. Thanks for also the Marvision for the as a management event. And I'd like also to mention there is a lot of questions they are sending that they are not having the, but I can see the link available in the chat. So everyone, just please go to the chat and you will find the link there to get the certificate. Thank you all. And we hope to see you inshallah next year with another and more proper inshallah and well organizing. And we are having a lot of surprises for the next year regarding the MEOM activities. Thank you all, and Happy New Year inshallah.
Happy New Year,
And
inshallah.
see you next year inshallah.
Assalamu
Thank you very
alaikum.
much, and Assalamu alaikum wa rahmatullah.
Thank you.
Bye bye.
Thank you.
Goodbye.
Assalamu alaikum.
Thank
Assalamu
you.
alaikum.